Hello and welcome. Today we are going to talk about natural language processing of nursing data for better clinical decision support. My name is Max Topes. I'm an associate professor of nursing at the School of Nursing, Columbia University in New York. So in terms of the take-home message for today I'm going to be talking about natural language processing, which can help to automatically extract important insights from millions of nursing clinical notes. In terms of the talk outline, I'm going to present you with my brief personal bio so you know how I got here. Then we are going to set the stage and talk about varieties of and millions of nursing clinical notes that are available for us. Then we are going to talk about definitions and specific examples of natural language processing in nursing. And then we are going to stress how this technology can help us do better decision making. And then we will have some time for questions and answers. Just to mention, this is the first part of the presentation, and we will have another more expanded part talking about methodologies and specific example of an open access software later in a few hours today. So this is the place where I was born, a beautiful place. So this is Siberia in former Soviet Union, Russia. Although my hometown looked something like that, so industrial town in the middle of Ural Mountains. This is my first computer. I basically had to hook up this metal box with the keyboard to the TV to display what is going on, to the tape to upload the software. And then I had to make it all work to play a Soviet version of the Mario game. So it wasn't very exciting, but that's how I developed my passion for informatics. Next, I immigrated to Israel, where I was a medic in the Israeli army. And that's where I was fortunate to be implementing some of the first electronic health records in the army. So this is where I became passionate about combining both healthcare and technology. And I saw some potential what technology can do for us in healthcare. I then proceeded to study for my bachelor's and master's degrees in nursing at the University of Haifa, which is this beautiful place. I worked at Rambam Hospital, which is that beautiful place, in the medical surgical unit. So my clinical experience mostly from there. I then became a Fulbright Fellow and joined the University of Pennsylvania PhD program. My advisor was Dr. Katie Bowles and Dr. Mary Naylor, and I studied how to create clinical decision support tools and do a lot of informatics work. Then I went on and continued to study for my postdoctoral degree at the Harvard Medical School with Dr. Li Zhao and Dr. David Bates. That's where I learned about the natural language processing technology that we will be talking about today. I then went back for a few years to head a health informatics lab at the University of Haifa. And then a few years ago, I became an associate professor at Columbia University. So I'm jointly appointed at the School of Nursing and at the Data Science Institute. And I'm also privileged to work for the Visiting Nurse Services of New York, which is one of the largest non-for-profit home care organizations in the United States, and we serve about 44,000 patients every day. So I'm fortunate to have access to this patient's data and help the visiting nurse services achieve their goal through information technology, through advanced informatics methods. So this is my motto: nursing data for good. So let's talk about health data variety. So today, what we know about our patients, and we know quite a lot, and much of this data comes from a variety of data sources, right? So these data sources might be labs, some medication data, data that is coming from emails, scheduling data, and other multiple varieties of data that are available today for us when we think about a patient. However, about 80% of this data is recorded in narrative format. And some of the examples of those narratives format are nursing or physician clinical notes. For example, admission, assessment, follow-up, comments, discharge notes, radiology notes. and so many others, just unimaginable variety of any other types of clinical notes that we generate about a patient today. Next, we have a large body of communications about patients that includes emails, text messages, administrative communications, and many, many other communications about the patient. We then have a very large body of scientific literature that can help us provide better care for patients. So currently, right now, PubMed database has about 27 million of articles. That is an unimaginable amount. You know, it will take a lot of years for all of us to read through a portion of this. So this is the scope of what is available out there in the free text. Now, this is my personal example. When I was working in the hospital, I noticed that patients would come to the hospital, would be admitted to the hospital. For some of those patients, there will be a bunch of diagnoses, but some of the important diagnoses, key diagnoses, would be missed in the structured data that describes patient conditions, basically, right? So, and what I frequently would see in the text would be something like patient is taking antidepressants regularly, or patient has depression. She has MDD, which is an abbreviation for major depressive disorders. But this would not be indicated on the structured problems lists for patients. This was concerning for me, and I started thinking about the ways that we can extract this data hidden in the free text clinical notes. So what can be helpful to extract those important insights about the patient from clinical notes? This is a technology that's called natural language processing. So what is natural language processing? Natural language processing is a field that combines computer science, artificial intelligence, and computational linguistics concerned with interactions between computers and human natural languages, right? So we call natural languages human languages versus very structured and very formal languages such as Java or C++ or even R language, right? So those are computer languages. When we add health to the mix, we get health NLP. NLP is a common abbreviation for natural language processing. So our major goal is to teach computers how to understand clinician or patient recorded information in the unstructured format, right? In those narrative formats, including clinical notes, social media data, lab reports, and any other types of information. So in terms of natural language processing methods, we would not dive deep into those methods at this part of the presentation, but next part of the presentation really focuses on those two types of methods, rule-based methods versus machine learning methods. And we will really present a software that can help you apply your natural language processing approach on your data. But today we are going to look at 4 examples of natural language processing and how it can be helpful for nursing. Example number 1. In this study, we show that natural language processing can identify ineffective self-management that is associated with rehospitalizations among patients with heart failure. So in terms of the background, effective self-management can decrease up to 50% of heart failure hospitalizations. Unfortunately, self-management by patients with heart failure remains poor. So in terms of methods, what we did in this study is we basically understanding that much of self-management information is captured in the free text clinical notes, right? And we didn't even have structured categories, right? So those drop-down boxes that you can click on that would identify that somebody has problems with self-management. So understanding that, we wanted to build a natural language processing pipeline to identify ineffective self-management status in the domains of diet, physical activity, medication adherence, and adherence to clinician appointments. So this is an example of how the system works. So you can see that this example, right, we have those domains in box named A. So those are the 5 poor adherence domains. And we want the system, this natural language processing system, basically, to be able to read clinical notes and automatically understand whether there is a documentation of poor medication adherence, for example, right? And you can see an example of a clinical note in box B. So this clinical note, it is a discharge note. It says the patient has not been fully compliant with her medication regime. We want the computer to be able to understand that this is an indication of poor medication adherence. And then it is indicated that the patient failed to attend appointments. We want the computer to automatically mark it up as missed medical encounters. So in terms of the results, we were able to create a natural language processing system that achieved relatively high accuracy. And how do we know whether those systems that we are creating, are they accurate or not? So what we usually do is that we would have two experts, that's what we had in this case, so two registered nurses, that would manually review a subset of about 300 clinical notes and mark each note as either positive or negative for ineffective self-management. We would then apply a natural language algorithm, natural language processing algorithm that we developed on those clinical notes and see how the software matches what the humans have said, right? So how good is the software in basically identifying what humans have found? And we believe humans 100% in this case. So in terms of results, in this database, we had a pretty large number of patients, so about 9,000 patients with about 35,000 discharge notes, because they were admitted to hospitals multiple times during the period of 3 years of the study. We found that for about 14% of those patients, there was a documentation of ineffective heart failure self-management. So this is one finding, right? That's one thing that you can do with natural language processing, identifying patients who are struggling with self-management. We then conducted an adjusted regression analysis that indicated the presence of any skill-related self-management deficits and non-specific ineffective self-management were significantly associated with rehospitalizations. So this shows that natural language processing approaches can really help to tease out those associations between what is written in the text and patient risk for readmission. Let's look at another example, example number 2. Here in this study, we use natural language processing to automatically extract wound information from clinical notes. So the objective of this study was to extract wound information from free text clinical notes. So we wanted to create the system that would automatically identify wound type, pressure ulcer stage, wound size, anatomic location, and wound treatment in the clinical notes. So description of wound treatments is a common, and description of wound presence is a common nursing domain that is documented a lot in the clinical notes actually by nurses, and very infrequently we would find systems that would appropriately describe all of those pieces that are needed to understand what was the progression of wound healing and what were some of the interventions that were helpful. So the goal of the study was basically to develop a system that would be able to read clinical notes and understand information about the wound. So in terms of methods, we again had a testing sample of about 360 notes, and these notes included discharge summaries and outpatient notes, and we had some sample of those notes dedicated to developing the natural language processing system. So in step number 2, we basically trained and tested the natural language processing system to process wound information, and we then compared the findings of this natural language processing system against the gold standard. So again, implemented the natural language processing system on human expert reviewed subset of clinical notes. We then compared the prevalence of wound cases identified from free text data with coded diagnoses in the structured data to be able to estimate to what extent and how much of missing data there is when you just look at the codes, at the medical problems that are indicated in the clinical record. So this is a conceptual description of the study. On the left-hand side, you would see that there is a patient wound care that is happening. In the middle of this diagram, we see an example section from a clinical note that describes treatment for wound. So today, I visit patients with chronic venous stasis with RLE. So RLE is an abbreviation for right lower extremity ulcers, treated with Silvadene. And you can see at the bottom of this description, there is a description of wound size. So wound size was very specific here. And you can see the variety, or you can kind of imagine the variety of ways each nurse and each physician would describe wound sizes. So in terms of results, our system achieved good overall performance. So the overall F measure was about 93%, so overall system accuracy, with best results for wound treatment, so we achieved best accuracy there, and poorest results for wound size descriptions. As I said, wound size descriptions varied so much between providers, it was hard to identify a common pattern. Now, only about less than a half of wound nodes had a structured code for wound diagnosis associated with them. So this is a concerning finding, right? And imagine what implications would that have on any types of research you would do with health data. So if by only looking at the structured data, right, the patient's problems, we are missing half of the wounds basically for patients, then you really need to do something like natural language processing to identify all the patients who are presented with wounds, who had wounds. And this is an extract from another study that we did in order to identify in order to identify social risk factors in physician notes related to hospital readmissions. So black bars represent the amount of information that would come from the structured data. And you can look at the first example of tobacco use. So the first couple of lines. So in tobacco use and smoking status, when we looked at the structured data, so only patients' problem lists, we would find that about 15% of patients are smokers. When we added, and when we did this natural language processing and added information that comes from free text to the mix, we basically identified 15% more of patients that are smokers or were past smokers, which basically means that you have to look at the free text data to identify all the people who are smokers. And you can see that for many other social risk factors, that was the story. So for alcohol abuse, drug abuse, depression, when only looking at the problem lists, right, from the diagnosis lists and other types of problem lists about patients, you would miss a lot of important information. So about 50% of important information about those patients. Now, with the caveat that, some domains are not documented in the clinical notes at all. So poor social support, for example, was not well documented at all. Now, example number 3, predicting patient hospitalizations and emergency department visits using clinical notes. So in this study, what is known that up to 30% are hospitalized or visit ED during home care. Nursing data can help to identify hospital patients at risk for poor outcomes. For example, there is a study that was funded by the National Institute of Nursing Research, led by Collins and Keita, that showed that we can identify patients who are failing in the hospital, who would require, for example, rapid response teams, or who would develop cardiac arrest up to 26 hours prior to an event. The question in this study was, can we use nursing notes to predict who is going to be hospitalized or visit ED in the home care? Home care is a very different setting from the hospital, right? You can imagine that other data are available in home care, but that was the hypothesis for this study. Now, in terms of the data, we had access to a large database with about 110,000 patients. Those patients had about 700,000 clinical notes written for them. We extracted hospitalization or emergency department visit information from structured data. And then we implemented several machine learning algorithms about which we are going to talk in the second part of this presentation more in detail. So we use those to create a predictive model that basically identifies patients who are going to be admitted to the hospital or ED. So here's the accuracy of those machine learning algorithms, and the best algorithm called random forest achieved about 80% accuracy in identifying, just using the clinical notes and identifying patients who are going to be admitted to hospitals. Now, these are some of the words and expressions that were associated with higher risk of hospitalization or emergency department visit. So this is just some selected words. And you can see that those words, they represent important and concerning clinical concepts, such as dehydration, vomiting, communication between health providers, for example, MD call, social risk factors, so leaves alone, on income mentioned. So things like that, they give a hint to us about patient risk. And that's what we saw in this data. So in terms of the discussion for that, home care notes are highly informative to identification of patients' risk. Imagine a system that will proactively identify patients at risk and alert nurses on those concerning trends. Wouldn't that be cool? Last example. Here in this study, we used automated speech recognition to help assess shared decision-making and predict medication adherence from audio recordings of primary care encounters. So in this study, just in terms of the background, asthma is a very common chronic condition. About 19 million of US adults suffer from asthma. We know that inhaled corticosteroids, which are a common and ideal treatment for asthma, but adherence to those medications remains poor. And we know that shared decision-making and patient activation strategy can improve patient adherence with medications. Now, in this study, what was available to us are 80 recorded encounters between primary care providers and nurse practitioners and patients with asthma. So all of those encounters were recorded. So the goals of the study basically were to use those audio recorded encounters and use natural language processing to evaluate the level of shared decision-making during the encounter. And this level of shared decision-making was assessed by asking a patient about shared decision-making. We also wanted to predict levels of patient medication adherence. In terms of methods, we used standardized tools to assess shared decision-making and medication adherence. We used speech-to-text algorithms to convert spoken language, right, so this recorded data, to the written language, basically, to convert them, to convert those conversations into the text. We then used machine learning to create predictive algorithms. So in terms of results, the accuracy of speech predictive algorithms was pretty good. It was about 88% for predicting shared decision-making and describing medication adherence for those patients. So this is an example. These are some of the words that the computer was able to identify as predictive of shared decision-making. And you can see that some of those words, they make a lot of sense. They are very likely to be included in shared decision-making. So when good shared decision-making is implemented, those words basically should be present in the conversation. But basically, imagine a world where automated systems that would listen to our conversations with patients would create automated nursing care quality control. For example, we were able to assess shared decision-making in this study. Imagine a world where automated systems like that would listen to our conversations with patients will automatically predict patient outcomes, right? So then we can intervene appropriately when interventions are needed. So we actually created a system, an open access, nursing sensitive natural language processing system called NimbleMiner that we are going to look at in the next part of this presentation that can be used to implement nursing natural language processing projects. So I just wanted to share a couple of examples of further projects that we are working on right now or we finished. So just to give you examples of some of the domains of natural language processing application. So in one study, we looked at extracting fall-related information from clinical notes. In another study, study number 2 here, we used natural language processing to identify dementia symptoms and show that patients with dementia symptoms have more hospitalizations and emergency department visits in home care. In another study that is ongoing right now, I, with my colleagues, developed a natural language processing system that identifies symptoms in hospitals and home care. So if anybody is interested in symptom science, further symptom science, please contact us. And in the next part of this presentation, I will give you a specific example of a study that we are conducting right now, focused on identifying symptoms for COVID-19 in ED clinical notes, so emergency department clinical notes. So in terms of summary, we described briefly the natural language processing, then we gave some examples of self-management status, wound information, and other domains in which natural language processing can be helpful. Next is going to be, we are going to share results of systematic review and provide a step-by-step guide on natural language processing using the software that my team has developed. So to finish that, I have this quote: "In God we trust, but all others must bring nursing data." Thank you so much. Now we have a few minutes for questions.